and we're kind of coming up close to the end of the academic year. So I think we have maybe 3 or 4 other of these lectures left. And then I think we may take some sort of a break and then probably begin again sometime in the early summer. We'll post everybody the schedule for how we're going to make this work going forward. And we hope to be able to offer the live sessions to a wider audience. So we're exploring that option as well. So today we're going to talk about metastatic lesions. This isn't something that you need to spend a lot of time with for the board examination, but it is something that's probably just worth knowing a little bit about because they might have a question or two on there. So there's some general principles that we kind of want to know about when you're dealing with the metastasis. One of the things you can see in this picture here, even though we don't really know what the diagnosis is yet, is notice that there's a dermal-based neoplasm, and notice that it's almost as deep as it is wide. And when you see that pattern, especially if you're dealing with a metastatic melanoma, for example, which this often happens to be, that's a very good clue that it's more likely to be a metastasis than a primary. Most nodular melanomas, by the time they get that deep in the dermis here, are usually, you know, 1 centimeter, 2 centimeters broad. They don't just kind of dive deeply into the dermis quickly. Some of them do, but that's rare. So when you see something that looks deep and it's malignant, but it doesn't have a lot of epidermal involvement, is relatively thin, that should be a clue that you may be dealing with metastasis rather than a primary lesion. So as we go to higher magnification, the other thing that we often see with metastases, obviously, is no involvement of the epidermis, or if there is involvement in the epidermis, it's maybe secondary, you get an ulceration or something like that. Here's this one of the 3 sections. You can see there's a nice grin zone. There's a little bit of papillary dermis present, maybe even some reticulodermis between the neoplasm and the epidermis. So that's another clue that you're dealing with metastasis. So one is if you get a nodule in the dermis with no epidermal involvement. Another is if you get neoplastic cells within lymphatics or blood vessels. That's another clue to malignancy, metastatic malignancy. And then the third pattern that we commonly see is a diffuse pattern. Cells between an oncology bundles diffusely, like we see, for example, with breast cancer that we'll talk about a little bit later on. And then another is if you get a deep cancer where you get something way down in the subcutaneous fat, that's also a sign of metastasis. And you also hear the term recurrence. I'll just mention that too. Recurrence, I don't like the term because it basically means something is gone and then it recurs. It's just kind of generic term, but there's sort of 2 ways that things recur in medicine. One is where you don't remove it completely. You think you got it out, and then time goes a little bit further, and then it comes right back at that actual site. So like, for example, we talk about recurrent nevi. Those are lesions that recur because we didn't get out all the melanocytes and they regrow. Surgeons refer to recurrent as cutting something out, like taking out some, mastectomy, remove a complete breast, and then it comes back maybe, in the arm or in the back or another location. They say, that's recurrent breast cancer. Well, it's really metastatic breast cancer. It's not really recurrent in the same sense as recurrent nevus is, but just so you'll know that surgeons and others talk about recurrences that a lot of us sort of really would more accurately talk about as metastasis. So just realize that's out there. So a surgeon, for example, might call this a recurrent melanoma. We would more precisely call this a metastatic melanoma, not recurrent at the site where somebody had inadequately removed a melanoma. And that's why it's kind of important in a way to make that distinction, because if you don't take out a melanoma with a wide enough margin, so let's say it's melanoma in situ, and you leave some at the edge, and then it comes back maybe a year later and actually has an invasive component, well, that's, maybe a recurrent, quote, melanoma at that site that actually then had a little bit of dermal involvement when it did recur, versus a lesion that was completely excised and nothing was left there. And then the person pops up with a lesion like this, maybe slightly away from the scar, or maybe in the scar, which sometimes metastases go to the scar tissue. That doesn't mean that they weren't adequately excised. It just means that they sort of like places where the blood flow is abnormal and lymphatic flow is abnormal. That's where the malignant cells can sometimes set up shop. So they maybe really removed it, but it recurred in the scar. And so it's metastasized to the scar. So anyway, it's just a way to understand and to think about those various things. So here we got a nodular neoplasm in the dermis. It's got multiple little nodular aggregations. And so if you look at it, and you're not going to be you're not going to really be tested on the cytology and the differential diagnosis, the distinction of some of these poorly differentiated metastatic lesions that you really can't tell. So something like this, they wouldn't just expect you to look at this and say, that's obviously metastatic melanoma. It isn't obviously metastatic melanoma because it's just comprised of just these very atypical small basophilic uniform cells that are pleomorphic. And, this could possibly be another type of metastatic epithelial neoplasm that's simulating one another. And it's hard to be sure. There's no melanin here. There's no, maybe there's some nesting in this little nodule at the bottom, but this is just a pretty nondescript metastasis of a neoplasm. And they're not going to expect you to know for sure that this is melanoma. So don't worry too much about that. I think the main thing is just recognize you've got multiple nodular aggregations of atypical cells with no involvement of the epidermis. That's one of the patterns of metastasis. And one of the most common neoplasms that metastasize to the skin is malignant melanoma, because they obviously start in the skin. So that's one pattern of melanoma. Now here's another pattern of metastatic melanoma. I mentioned this to you before a second ago, is that you can get lymphovascular involvement. And here we've got blood vessels that are chock full of these atypical melanoma cells here. So here you can see that's actually a vascular or lymphovascular space. Over here, you don't even need a special stain to highlight the fact that there's obviously endothelial cells at the periphery, and these melanoma cells are sitting in the middle of that. So not a good prognostic sign when you get that. And that's, I'd say, relatively uncommon to see melanoma in that situation. Most of the time we see melanoma, it's like that first case where you get these big nodular cannonball type mets. It's less common to see this pattern. Now, one thing I will mention about this, just another sort of educational point here. Sometimes you see cells like this, and you can't really tell if they're in blood vessels or not. This probably, given the fact that those others are in blood vessels, most likely is. But sometimes you'll just see a puddle of atypical melanocytes like this sitting in the dermis. They usually have a prominent nucleus like here, and maybe you'll see the nucleolus, usually have abundant melanin and relatively ample cytoplasm. It kind of looks a little bit like a funny blue nevus, but it doesn't have any dendritic cells. It's not clearly a cellular blue nevus. It doesn't really have a lot of striking atypicality. You may not see any mitotic figures. So this is what you see in the so-called blue nevus-like metastatic melanoma. And this really looks pretty similar to that. And so even though these are most likely within vascular spaces here, if there were no vascular spaces, it would be this so-called blue nevus-like metastatic melanoma. And you see these patients clinically, they often have these little freckles, little sort of specks on the areas. They can sometimes have hundreds of these lesions. And when you biopsy them, this is kind of what they look like. And if you just see that without any information, it's sent into you with, neoplasm certain behavior or real blue nevus or something like that, you could easily undercall that. So you have to understand that the blue nevus-like metastatic melanoma can look pretty bland, and it doesn't have a lot of cytologic atypia. So you have to have an index of suspicion and realize that that's one subtype of metastatic malignant melanoma. But this is kind of a cool case because it's got these cells that actually are in blood vessels, and probably these cells out here are also melanoma cells. This is kind of analogous to what you see in people that get that slate gray pigmentation with metastatic melanoma, that melanosis. This is what that looks like. That's why they get that in that situation. Okay, so let's switch over to another lesion here. Go down, we'll take a look at this top one. So notice again, we've got the same basic pattern. We've got dermal involvement. So again, you think of a dermal nodular neoplasm, think metastasis. Doesn't have to be metastatic disease, but you should at least think about it. So when you're coming up with a differential diagnosis, basically say, okay, well, this could be a metastasis when it's like this. And here, so at higher magnification, you see that it's epithelial as opposed to non-epithelial. And they're also ducts, okay? And then if you also look at some of these areas down here, you can see that these cells are kind of arranged in these little cords and strands diffusely in the collagen bundles down here. It's a good example of that pattern down here at the base. It's getting into the subcutaneous fat a little bit here. Another example of this over here, where you get these cord strands of cells between and among collagen bundles with these areas of obvious ductal differentiation. So this is an adenocarcinoma. Anytime you get glandular differentiation, it's adeno-CA. And if you see what looks like some glandular areas like this, plus these cords and strands, the number one diagnosis that you should make is metastatic breast cancer. If the board's going to ask you about a metastatic epithelial neoplasm of the skin, I would say probably the most likely one they're going to ask you about is going to be metastatic breast cancer, because it's got this characteristic pattern of these sort of so-called Indian file cords and strands of cells between among the collagen bundles. So when you think about a metastatic lesion to the skin, they can either kind of occur as a nodular aggregation, or the neoplastic cells are kind of basically floating freely in the vascular and lymphatic spaces. They get to the skin and they just kind of splay out between the collagen bundles like here. And that's also whenever you see that pattern, that interstitial mostly pattern that we've talked about before, like with GA and patch plaque Kaposi sarcoma and some things like that, you should put in the differential metastatic carcinoma, metastatic breast carcinoma, interstitial mostly. And sometimes they don't have to be these large aggregations with these obvious areas of adenocarcinoma differentiation. Sometimes you just get really single cells, fine, thin cords and strands of cells. It can be really subtle. And you might even have to have an immunoperoxidase stain for cytokeratin to identify them. Here, it's no problem, but we do have some cases where they can be a lot more subtle and more difficult to pick up. Like over here, for example, here's still metastatic breast cancer, but notice you've only just got these scattered small little aggregations here. And sometimes that's it. That's the whole pattern, or just these little small strands and cords like you see here with no obvious glandular differentiation, no mucin, nothing like that in there. So you have to have an index of suspicion. And if somebody's got a prior breast cancer, older woman or something like that, that presents with this firm, erythematous rock hard plaque, you want to biopsy that and look for that pattern. The other thing is there's a lot of different patterns of metastatic breast cancer. That's not really in the scope of a dermatology board examination, so you really don't need to know that. I mean, there's about 7 or 8 different types of breast cancer that metastasize to the skin. You mainly need to know that pattern, and that's pretty much it. So don't spend a whole lot of time, fretting over that. Now, there are a couple of other adenocarcinomas that metastasize to the skin that have some characteristic patterns. Just to kind of hit a highlight or two of those. Again, notice we've got this nodular aggregation of these cells in the dermis with nothing involving the epidermis. Again, a pattern that we really focus and consider for a metastatic adenocarcinoma. And here you can see that this has obviously got glandular differentiation. And this time, notice it's got all these sort of atypical mitotic figures in the necrotic cells and this degeneration of this material in the center of the lumen of these. This is very characteristic of what we see with metastatic colon cancer. So they talk about dirty necrosis. These cells are dying, so they're necrotic, they're apoptotic, and then it leaves you this kind of degenerated pink amorphous material in the center of the glands. So if you want to remember one sort of pearl for metastatic colon cancer, it's metastatic adenocarcinoma of the colon. Just remember dirty necrosis. So these cells are cuboidal. They don't really have a lot of mucin in the cytoplasm, maybe a little bit of that, but notice it's just got all these necrotic degenerated cells here with this pink sort of amorphous material in the center of these glands. So that's metastatic colon cancer. Okay. Another one that you really do need to know a little bit about here, that this is one that you probably will get a question on. And what they probably would do here, I might show you a clinical picture of somebody that's got a big red lesion on the scalp. It looks bloody. They might show you a biopsy to go along with it, and it shows this nodular aggregation. Once again, notice there's no involvement of the epidermis here. It's a nodular cannonball type of lesion. So again, you think about a metastasis, and it's very, very bloody. As you can see, lots of vascular spaces here, lots of extravasated erythrocytes. And then look to the side of those, you see these clear staining areas here, these clear staining cells that are forming these little primitive nephrons. And so this is a metastatic renal cell carcinoma. Now, this is one that they probably very well could ask you about, because this is the classic thing that we teach dermatology residents, that if you get a very hemorrhagic lesion that's often pulsatile, it's on the scalp, the head and neck area, and you biopsy and it shows this clear staining area with all these vascular areas within it and lots of extravasated red cells, and it's just loaded with red cells like this. This is classic for renal cell carcinoma. And then obviously, remember the syndromes that are associated with renal cell carcinoma. Birt-Hogg-Dubé can have renal cell carcinoma. So there's a couple of other syndromes that you need to make sure you brush up on that can be associated with renal cell carcinoma. The one interesting thing about the renal cell carcinomas that come from a syndrome versus the renal cell carcinomas that come from non-syndromic situations is that the syndromes tend to have a better prognosis. So if you got Birt-Hogg-Dubé and you get a renal cell carcinoma, even if it metastasizes, you're likely to do better than if you have just the one that develops de novo later in life. In renal cell carcinoma, compared to other types of carcinomas, when it does metastasize, as opposed to say breast or melanoma, something like that, tends to have a somewhat better prognosis. Not just the germline version, but the other type too are somewhat better than some of the other types of metastases that we see in the skin. So might get a question on metastatic colon cancer, unlikely. Possibly for metastatic melanoma or breast cancer, very likely to get at least a question somewhere in the exam about metastatic renal cell carcinoma, either syndrome associated with it, maybe a pathology slide that looks like this associated with it, maybe a clinical pathologic slide. So this is one I think you really should make sure that you at least know what the histology looks like, the clear cells with all the vascularity to it, and the bloody, quote, nature of the lesion. That's really classic for metastatic renal cell carcinoma. And this one's a little bit more esoteric. You almost certainly will not have this, but just thought I would show it to you anyway. Another metastatic lesion. You start looking at it and say, well, you know, there are these clear, actually they're mostly cuboidal cells. There's some necrosis on moss, which we all know is associated with malignancy. And then if you look in this area here, you've got this pink, almost hyaline, almost like pink jello, if you will, and it's hot pink. It's not just bubblegum pink like you see in the collagen models over here. It's kind of this reddish pink color, and that's thyroglobulin. And so you see some clear cells here, some cuboidal cells here. You got the thyroglobulin over here. So this is a metastatic thyroid carcinoma. I doubt that you're going to get a question about this. So, but this is what they look like. They're very characteristic, give you these very cuboidal cells. Some of them have a little more clear staining cytoplasm than others. They can have, you know, a little bit of a almost, well, here's a gland, you know, forming a little sort of a lumen here. And then you see the thyroglobulin in the center of the glandular structures. So it's a nice example of it. We don't see it that frequently in dermatopathology. I mean, we diagnose maybe a few of these a year. So anything that's esoteric, they're probably not going to show you on the exam. But just in case, just remember, if you see something that looks like it's a dermal-based nodule, it looks like it could be a metastatic lesion, and then you see that pink material in the center of some of the glands, think metastatic thyroid cancer. But I wouldn't really bank on getting one of these. Renal, yeah, you're going to get that, but not one of this. This is just an interesting case. This actually was a thyroid transcription factor. We thought I'd just show it to you because it's kind of cool. You all remember TTF1 is basically the stain we use for determining whether something is metastatic small cell carcinoma from the lung or from another location versus primary Merkel cell carcinoma. Merkel cell carcinoma usually doesn't express TTF1. Well, it's called thyroid transcription factor 1 because it actually is expressed in thyroid tissue. And so even though it also gets expressed in neuroendocrine carcinoma, small cell cancer, it's expressed in the thyroid gland too, obviously. So this is the TTF1 stain of that metastatic thyroid cancer. It's a beautiful example of that. Again, I don't think you're going to get that on the exam, but just to realize that that's another example of how TTF1 can be expressed. Okay, another example of a metastatic carcinoma. Again, it's sort of it's something like this. If they did ask you something, they would probably just ask you something generic. I remember on my exam many years ago, they I think they showed us a picture of an AFX or something like that. And they just asked something generic about whether it was benign or malignant and what kind of workup you might do. They wouldn't expect you just to look at this and say, this is metastatic tonsillar cancer, which is what it happens to be. You can just see that it's basically, again, a dermal based nodular aggregation of atypical cells. And so if you just saw something like this in a vacuum, you can't really be sure it's not even metastatic melanoma for that matter, or even a weird metastatic neurocarcinoma. So I think really on something like this, they might just ask, do you think that if this is benign or malignant, and what kind of workup might you do? Would you do some kind of an internal workup, maybe looking for a CT scan or, LDH levels, something like that. So if they were going to ask you something about this, they're not going to ask you about the specific differentiation. They might, I don't even think they would ask you whether this is even epithelial or non-epithelial. So again, there's lots of atypical lesions that metastasize to the skin. Again, the principle is looking at the overall pattern. Is there any involvement of the epidermis or not? And then if there are any other features that can be kind of helpful to, like glandular differentiation, that sort of interstitial mostly pattern, if there's evidence of melanin or nesting, those sort of things, those can help you. But something like this, they probably wouldn't really be focusing on really a lot of detailed information about that. This is one that we do encounter in dermatology, not infrequently. This is one that they might ask you about, because if you're, dermatologic surgeons, they contribute some of the questions to the board also. And notice once again here, we've got what looks like a squamous cell carcinoma in the dermis. So hopefully you'll be able to recognize that. It's pink. It's got cornification. Cells you got some acantholysis, some atypical cells, mitotic figures, pleomorphisms. This is cancer for sure. And it's obviously squamous cancer. So again, if you're able to diagnose this as a squamous cell carcinoma, you should be able to do that. And we've obviously talked about squamous cell carcinoma in this conference over the last year, and you've seen that in other settings as well. And notice once again, there's a separation. There's a space between the epidermis and the dermis. There's no direct contiguity. And notice that there's no atypical keratinocytic proliferation of the overlying epidermis. So there's no actinic keratosis here. There's no evidence of squamous cell in the epidermis. And then this has got a space between the cancer and the epidermis. So that's going to favor a metastatic cancer once again. And here we're dealing with metastatic squamous cell carcinoma. So this is one that we do see fairly frequently in dermatology. Somebody that has a squamous cell carcinoma that's excised, basically a lump comes back in the area 6 months or a year later, you biopsy it and it shows this pattern. And then that may be a local metastasis of the squamous cell that was removed perhaps by Mohs. It was completely removed, but there may have been a few residual cells there that were subclinical. There may have been some cells sitting in a nerve that weren't picked up. And that's one of the things that you do need to look for whenever you're looking for squamous cell carcinoma that's involving the dermis, is where there's any nerve involvement. And those are usually going to be the deeper nerves. We sort of don't get as concerned. You know good and well that if there's this much tumor, I mean, there are nerves here and there's this much tumor, it's going to be wiping out nerve twigs along the way. But what we really look for is we go down into the fat and we see some large nerve twigs that are greater than about 0.1 millimeter in size. If we see evidence of nerve involvement in the nerve sheath around that nerve twig, that's a classic finding of neurotropic involvement. And we don't really see that here because this is just like solid mass of tumor cells, but that actually could be why this lesion recurred. It could have been sitting in a nerve, wasn't picked up because maybe a skip area, and then maybe after it was excised, everybody thought they cured the patient. Well, then these cells regrow out of that nerve. It's really almost like a little metastasis, if you will. The cells are sitting in that potential space between the epineurium or the perineurium and then the actual nerve. And there are sometimes individual cells that are floating in that CNS, basically CSF fluid that gets all the way down there, because there is fluid in there, just like there is in your central spinal area as well. So it's the same sort of thing, the CSF, and individual cells can get in there and float freely and end up spreading anywhere the nerves go, and all the way back into the brain for that matter. Usually they don't, but they can. So that may be how this lesion recurred here. But this is one that they very well might show you as the most likely diagnosis here. They might say primary squamous cell or metastatic squamous cell. And as you can see, there's clearly no atypical features in the epidermis. And then it's got this dermal-based nodular pattern, that's going to favor a metastatic as opposed to a primary squamous cell. So that's really the way that you would diagnose that. Okay, let's look at, this is another lesion. Okay, and they're not going to ask you what is the origin of the primary tumor here, but just notice this pattern again. It's a theme that we've talked about today. We can basically hammer it over and over again. And notice that this is sitting as just a nodule in the mid-dermis. So whenever you see that, you want to go down and look at a higher magnification, and you can see that these cells are atypical. They've got glandular differentiation, so they might have a differential diagnosis here, and they might list in there a metastatic adenocarcinoma. And again, so if you see a dermal-based nodule that's, you know, maybe as deep as it is wide, and it's got atypical cells and it's got glands in them, that's the diagnosis. It's an adenocarcinoma. Now, this happens to be prostate, but you don't need to know that. All you need to know is that this is an adenocarcinoma. It's glandular, it's atypical, it's got mitotic figures. The individual aggregations vary in size and shape. There's no well-defined capsule around it. This is one of the lesions that's a sort of breaks the rule of small and symmetrical, because these nodular mets can be relatively small and they can be symmetrical, and they can almost look well circumscribed, but they're not. They're actually splayed between them on collagen bundles in many cases, and they also have these atypical cells. So if ever you get a dermal nodule, you say, okay, that we know, you know, a small symmetrical circle, that's benign, but we go to higher magnification, we see these atypical cells. It's the exception to the rule. It's a metastasis. So that's an important thing to remember when you're applying architectural criteria, is that if you see it looks benign at low magnification, go to higher magnification, it's comprised of atypical cells, think about a metastasis. And if you see the glandular cells, it's an adenocarcinoma. And you don't necessarily need to know the type of adeno-CA. I'm not gonna make you do that. This is another lesion. And unfortunately, there may not be too terribly, yeah, there are some cells here, okay. And notice again, we basically just, here we've got a dermal-based lesion again with these very atypical cells in them. Some of them are a little bit discohesive here at the periphery. And this was metastatic lung cancer. So I'm just kind of showing you these examples of different metastases here. I don't know if this was a squamous cancer of the lung or maybe an adenosquamous. It's got some cells that look like they may be somewhat glandular focally in a couple of areas, but then you've got these cells over here that are pretty squamoid. So again, you can get both squamous cell carcinoma and adenocarcinoma of the lung, as well as small cell carcinoma of the lung. We don't actually happen to have one of those in today's lecture, but you guys have seen Merkel cell and Oat cell. We've shown those in other settings, and those are you get the small basophilic cells that have smudgy chromatin to them. And if you do stain it and it's positive for TTF1, like I mentioned earlier, that tends to favor metastatic small cell carcinoma, metastatic neuroendocrine carcinoma versus a primary Merkel cell carcinoma when it's got that pattern. So this just happens to be lung. And you notice the normal epidermis overlying it. One other rule of thumb is that the metastatic cancers sort of like to go, you know, the adenocarcinomas at least like to sort of go where they came from. You know, for example, a metastatic lung cancer tends to metastasize to the chest as opposed to the head and neck, something like that, if it's going to go to the skin. Metastatic prostate tends to be in the groin area, sort of close to where the prostate is. Or, you know, prostate actually also goes into bone, but the, you know, those lesions go to the bone, don't go to the skin too. So metastatic prostate usually in the groin. Metastatic breast, chest and the breast area. So they tend to like to go where they're from. Now, the renal cell, little exception there, that often goes to the scalp and can go anywhere in the body. Melanoma can go anywhere in the body also. It tends to go to the regional nodes, but if it gets into the bloodstream and spreads in a widespread fashion, that can go anywhere. So just remember that. But as a general rule, the metastatic carcinomas like to kind of go close to where they arose. So that's helpful. And then one other thing that I'll mention on the next slide. Okay, so another metastatic lesion that you can't tell the primary, and we don't expect you to know the primary. This happens to be metastatic bladder cancer in this case. So there's no way to tell that. All you know is just a metastatic, poorly differentiated epithelial neoplasm that's got no involvement in the epidermis. And over here, you see the kind of cords and strand pattern like we saw with the breast cancer a minute ago. So anytime you get that interstitial epithelial lesion, think about metastasis. It doesn't have to always be, but think about that. And the thing about the bladder cancer and the GU cancers, again, they like to metastasize close to where they came from, but they also can give you the Pagetoid pattern. So when you get extramammary Paget's disease in the groin or the perianal area, you should think about an underlying GU or GI cancer. And we've seen extramammary Paget's in this session before and in your unknown sessions. So remember what that looks like, the individual clear staining cells with abundant mucin sitting in the epidermis. And then if you sometimes look at those carefully, you may see some cells that have a somewhat glandular morphology. So that would favor maybe metastatic colon cancer or some type of GU cancer that's involving the skin secondarily, rather than the primary extramammary Paget's disease that is not associated with underlying cancer. So you always need to work up a patient that's got extramammary Paget's for possible underlying adenocarcinoma every single time. And same thing with mammary Paget's. It's always, always, always associated with an underlying intraductal breast cancer. So you just have to look for it. You have to find it. So you would never treat mammary Paget's disease just with a simple excision, for example, because you're going to leave cancer down in that person's breast that then could get spread more widely. So that needs to be worked up and found. And so the same thing is true with this, with extramammary Paget's. You want to always make sure that there's not an underlying cancer. And the board probably is going to ask you that. So you'll probably get a question somewhere about that. And that's an important sort of dangerous doctor question. You want to make sure that dermatologists know that if there's extramammary Paget's, they need to rule out an underlying adenocarcinoma of the GU or the GI tract. And it can be just about any of the cancers that involve that area. It can be prostate, bladder, it can be urethral, any of the cancers in the GU, GI tract can involve that area, colon, whatever. So just remember that. Okay, so last one. And once again, just to kind of drive home the point of just metastatic lesions. And again, this is a short talk, and it's short on by design, because I really don't want you to spend a ton of time focusing on this. You got a lot of other things to master before the exam. But this is, again, another metastatic adenocarcinoma, and this just happens to come from the pancreas this time. So just recognize the glands. So again, I want you to probably take home messages for this, or patterns that we've talked about, and then identifying the basic epithelial or non-epithelial structure. So if you can tell squamous epithelium, glandular epithelium, possibly neuroendocrine epithelium, renal, you definitely need to know, and then maybe melanocytic if it's got nesting and it's got melanoma and that sort of thing. Be able to recognize the general elements of those, and then the pattern of the nodular or the interstitial pattern that we talked about. And that's pretty much 99% of what you need to know for the metastatic carcinomas to the skin for your board examination. If you're going to go into dermatopathology, then maybe you need to know a bit more about how to work these up and make a definitive diagnosis using special stains. Sometimes we use prostate-specific antigen markers and RCC for renal cell carcinoma. We're not sure. And so there are some markers that you can use, but I don't really think you're going to get quizzed on that on the board. They really mainly are just going to want to test some general concepts here that you need to know about in just identifying that it's a metastasis to the skin, and then what kind of workup you might do. Probably the last thing I'll just mention that's, again, a little bit esoteric, is occasionally we get into a situation of a metastatic neoplasm that's ductal and looks like an adeno-CA versus possibly a primary adnexal carcinoma, like an eccrine carcinoma, or maybe the difference between maybe a metastatic ductal neoplasm versus maybe a funny microcystic adnexal carcinoma. That differential diagnosis is usually not all that difficult. Most of the time, the clinical presentation is different. They usually have evidence of some skin involvement, like a MAC. Usually is kind of whitish indurated plaque from the head neck area, whereas these lesions, again, usually do not involve the actual epidermis. And in my experience, it's usually not too difficult to distinguish those. Some people talk about using special stains, like if you stain for androgen markers, progesterone, some things like that. Those tend to be more commonly expressed in some of the lesions that spread to the skin. You know, if you're saying differential might be a breast cancer versus an axial carcinoma, which I've really never seen as a difficult differential, really. But they don't. The caveat on those is those stains don't always work. You can get some of those markers also stain primary adnexal carcinomas also, or primary benign adnexal neoplasms as well. So you can't really rely on those. If there's a concern about that, you really have to go back to clinical and work the patient up and see if there's an underlying carcinoma. You can't just do a couple stains and say, it's going to be primary, it can't be metastatic. If there really and truly is a differential that you really need to make between those two. It's not usually that difficult, but it happens on some occasions. And so just know those general concepts. All right, well, thank you again for your attention. Again, I believe we will talk again next Wednesday. And I think next week we're going to be talking about the interface dermatitis with lichenoid inflammatory infiltrates. That's an important one. And that's one you definitely do need to know. You need to know that in detail. And you will be getting some questions about that on the exam for sure. So hope you enjoyed the session today. Hope you got some general concepts about metastatic neoplasms. And we will see you on